Yes, sir. Good morning, everyone. So this is the lecture in the series of pediatric rheumatology classes, e-classes that we've been having. So till now, we have covered approach to juvenile idiopathic arthritis, which is the commonest rheumatological illness in children. And that lecture covered all the treatment management, all the subtypes. The second lecture was on lupus. We also had a wonderful session by Dr. Ankur Jindal on scleroderma last week. It was very enlightening because scleroderma is very difficult in children to diagnose, to treat, has a lot of challenges. Then we also had a lecture on Dr. Sujata Sani ma'am, who took basically an approach to rheumatological illnesses, how to examine these patients, how to make a diagnosis, how to approach these patients, and and we also had a juvenile dermatomyositis lecture by Dr. Avinash sir, who's a professor in Tanda Medical College. He's DM from PGI Chandigarh, and that session touched beautifully upon juvenile dermatomyositis because it is one of the more severe autoimmune diseases in children, and if not treated in appropriate fashion, in a timely fashion, can lead to mortality as well. And today we have a lecture by Dr. Manjari, who will be taking on use of biologicals in pediatric rheumatology. You know, these biologicals are a very exciting field because they have transitioned from non-specific immunosuppression with its antecedent complications to, you know, personalized medicine tailored for the individual, tailored to the disease. And now we can also say, like, some children may have a genetic predisposition or genetic diseases that can be specifically targeted. Like, suppose we have mTOR inhibitors, we have IL-6 defects or IL-1 defects, which we do not need to give steroids, which are non-specific, lead to a lot of side effects. But we can specifically target the IL-6, we can specifically target the IL-17, leading to appropriate personalized medicine for the patient, good disease control, and minimization of side effects. So, biologicals is an interesting field. In fact, there was a very interesting article in NAGM where they talked about using etanercept anti-IL-6 inhibitors to prevent type 1 diabetes. That means when the diabetes starts in the honeymoon phase, if you start with biologicals, maybe it's able to prevent the attack on the pancreatic cells. So very, very exciting field and very, very exciting drugs. So I hope Manjari would be able to clarify a lot
Thank
of
you, Dr. Anu.
complications
Thank
for
you,
us.
Dr. Anu.
Yeah. Thank you.
On
Over
behalf
to
of IIP Delhi, I welcome Dr. Harish Pende sir, Vice President North Zone Central IIP, and Dr. Baljinder Kaur ma'am, EB member from Punjab Central IIP. She is head of the Department of Pediatrics at Government Medical College, Patiala. I request Dr. Harish Pende sir to please say a few words.
I think I am happy and privileged enough to participate in this very important series of programs on pediatric rheumatology. It's still a growing branch, and I'm also very happy that Dr. Anu is coordinating this thing, and she is leading this particular subspecialty in our hospital, that is Kalapati Children's Hospital and Medihari Medical College. And I am sure with this learned people are here to lecture and maybe answering the questions, and the participants will definitely benefit, and the recording of these sessions will also benefit later on the participants, the young ones and the old ones, everyone. And I'm sure this will help in developing this particular subspecialty of pediatrics in North India and all over the country. Thank you very much, Anu, and thank you very much all the faculty members.
Thank you, sir. I
Thank
request
you,
Dr.
sir.
Chamina to please introduce Dr. Baljinder.
Hello, good morning to all. Very warm welcome to Baljinder ma'am. Ma'am is a senior professor and head of the department, Government Medical College, Patiala. And thanks to madam accepting our request for chairing this session.
Thank you. Dr. Pankaj, you would like to say something? Dr. Pankaj?
Good morning, everybody. So, as IIP Delhi President, it's my pleasant duty to welcome Dr. Baljinder and Dr. Manjari for today's session, and of course our own Dr. Harish Pemde, Dr. Ajay, Dr. Anu, Dolly, and Dr. Sham. We are in the process of a midway of pediatric rheumatology course. This is the seventh lecture which is going to happen, and five more to go. And I'm sure that this is being enjoyed by many people online and then offline once the recordings are shared. And I can see the hits on those sessions have run into thousands. So that means people are looking at these sessions again and again also. Also, to remind you that we will be launching the pediatric cardiology master e-classes from tomorrow onwards. Those of you who are interested can join that session also. It is a continuous program from academic front from IIP Delhi, and we want to lead the country in academic front wherever possible, and this is just one step in that direction. So keep on enjoying the academic front with the IIP Delhi, and I again welcome all of you on this one. And over to Dr. Ajay.
Thank you, sir. Thank you, sir. I request Dr. Baljinder Kaur ma'am to please say a few words and invite Dr. Manjari.
Good morning, everyone, and congratulations to IIP Delhi for starting this initiative. Thank you, Dr. Atul, Dr. Harish, and all other dignitaries for involving me in this. Where general pediatrician is concerned, what we have seen as 1 to 2% of rheumatological cases which we see in OPD generally, and there is overusage of NSAIDs, overusage of steroids, sometimes overusage of cyclophosphamide. So today's lecture of biologicals in rheumatology is going to be very wonderful by Dr. Manjari Aggarwal, who is a senior rheumatologist in Sir Gangaram Hospital. Along with everyone, I am very keen to listen to her views on biologicals in rheumatology. Over to Dr. Manjari. Thank you.
Thank you so much, ma'am. Thank you, IIP Delhi, and thank you, Dr. Pankaj and Dr. Jessar, Dr. Anu, for this opportunity. I have to apologize that my other laptop is hanging in my final PPT is there. I'm just getting it here. So I'll just give you a little background till my PPT is coming in a pen drive on this laptop. So when we talk about biologics, when we talk about pediatric rheumatology and drugs, I think the game changer for pediatric rheumatology came when we had, sorry, just give me a second. Sorry, the lot of excitement about the festival today. So when we used to talk about pediatric rheumatology, the game changer came with the discovery of steroids. Before the steroids, the whole of probably adult rheumatology, pediatric rheumatology, everything was treated by giving a lot of non-steroidals. And these non-steroidals had a lot of problems. Gold salts used to be used. There was nothing that we could use in the form of treatment. In the form of treatment. Now we know that with the discovery of steroids, our game totally changed. And the game totally changed. We were able to get a lot of drugs. And with those lot of drugs, we were able to change the outcome of these patients. But the steroids came with their own problems. The steroids came with their own problems of a huge amount of side effects. They came with a huge amount of hypertension, osteopenia, osteoporosis, fractures, growth impairments, and so on and so forth. So there was a requirement to take away the steroid and yet keep the diseases at bay. Now came the disease modifying agents,
And these DMARDs were the ones which helped us. And but they had their own problems. Sometimes we had to use cytotoxic agents. These DMARDs were pretty effective, but they were not very specific. It's like, think about this, that you have a whole crowd, you have a mob and you want to disperse the mob. The police wants to disperse the mob. How would the police disperse the mob? The police would probably make some announcements that will be like NSAIDs. The police would probably use some lathi charge that will be like probably some steroid. And then the police would use probably a hand grenade or a tear gas, and that will be like the demands. But nobody is actually targeting the problem and the actual problem molecules which are getting excited. We don't know the reason, but we need to calm them down. We need to calm down the cells of the immune system, that is the T and the B cells. And when we will calm these cells down, so this is like a sniper. This is like a sniper coming and targeting a specific cell. It's either targeting a T cell or it's targeting a B cell. And this sniper is precise. So what have we avoided? We have avoided damaging a lot of other cells which were innocent. We have tried to damage control, we have tried to target specific cells, and we have then tried to prevent the organ damage. We have tried to prevent the organ damage caused by the disease modifying agents and caused by the steroids and caused by the NSAIDs over a long period of time. But everything comes at a cost. The tear gas was cheap, the lathi charge was cheaper, and the announcements were cheaper. So the sniper comes at a cost. He's a specialized person, he's targeting, his weapon is very expensive. So the cost of the biologicals inhibits and prohibits us from using them at large. The second thing is that these are relatively newer molecules. A biologic has come just now into fourth, probably 2 decades, probably 2.5 decades. So when we are using it on a young population, we are scared. We don't know what it's going to cause. The child who has received a biologic in 2020, 2000 or 2001 at 10 years of age is a 35-year-old individual who's looking at probably another 50, 55 years of life ahead of him. We don't know what these biologics have done to his genes. We don't know if this person is at an increased risk of a malignancy. We don't know if this person would accrue some damage over time. So there are registries. There are worldwide registries, a biker registry, a clipper registry, a IPOCA registry, a printer registry, a pharma child registry. And these are all international registries which accumulate all these children, and then we look at the side effects over a period of time. Long term registries, even from India, we have contributed to more than 100 children in these registries, because today at our center, at my center at Sir Gangaram Hospital, where I work with Dr. Sujata Sahni, we have used biologics in I think more than 1,000 children till date. And this is, I'm talking from 2001, since the time our pediatric rheumatology center started. I'm associated with the center. I joined my fellowship 2009. So till then, till date, we have more than 1,000 children who have received biologics. We do try to keep in touch. We do try to maintain our registry data. We do try to look at our own data to look at the safety and efficacy of these molecules. I'm happy to tell you that my PPT has come, and if you'll just give me 1 minute, I'll just start it. Thank you. All right, I'll just share my screen. Yep. My screen is visible, ma'am?
Yes, it's visible, Manjari. Just move your slides.
Yes, thank you so much. Right. So now, without wasting any time, and I promise I'll finish before time and not waste even a single moment of this precious Sunday. So, biologics, as I told you, these are target molecules, these are specific molecules. So, why do we call them biologics? We call them biologics because these are biological products. These may be blood components, anything and all. Most of these biological products are complex, unique, large mixtures. These are not like a paracetamol, not like a amoxi clav or a clavulanic acid or an antibiotic which can be easily replicated. These are very sensitive to heat, vulnerable to microbial adulteration, and require a lot of aseptic techniques from manufacturing techniques. These are also called as immunomodulators or cytokine inhibitors. So these are naturally occurring substances in our body, and they can be manufactured in the lab, and they target the disease causing mechanism, as we'll see subsequently. Now, another thing, we in India are at a very unique position because we have called something called as biosimilars. So I think no talk on biological demands today is complete without talking about biosimilars. What are biosimilars? So these are biologic molecules, but we have tried to copy them. Why was the need to copy them? Of course, the need to copy them was the biologics are very expensive. We cannot afford them. And if we want to use these biologicals, these targeted molecules, and want to really improve or impact the quality of life of our children who are suffering from these diseases, we need the biosimilars. So, Indian guidelines would define a biosimilar as a biological product which is produced by genetic engineering techniques and claimed to be similar in terms of safety, efficacy, and quality to a reference biologic, which has been authorized by the DGCI. The active substance of the biosimilar medicine is similar to that of the biological reference medicine, and it is used in the same dose to treat the same disease. But it is not a biologic, it is a biosimilar. So it becomes our duty to document this when you're using a innovative biologic or when you're using a biosimilar, because the drug companies are very happy to say that these are fingerprint molecules, these are clones, but they're not. You cannot have a same fingerprint whatever you may do. They are not clones, they are just similar, they are not true copies. So because these are very large molecules, very complex molecules, it is very difficult to copy them. Now, after having learned this, now let us look at some of the names. Some of the names may be sounding like tongue twisters, but I'll try to simplify it. And I'll try to tell you that when we look at the biologics at large, so let's step back and look at a big picture. Let's look at all the type of cells and all what we want to inhibit. So what I've done today, I'm just using a few common ones. I've just labeled them here, which we are using in India or which we are likely to use soon, so that we know what these molecules are. So the first and the foremost group that is used, which is the most old, the most biologics, the group with which we have got the most experience with, is TNF inhibitors. This TNF inhibitors blocks the TNF. TNF is tumor necrosis factor. It has got nothing to do with tumor or with necrosis, but it was just derived from these the cells which were necrosed. And this particular cytokine was expressed by the necrosed tumor cells. And that is why it was traditionally called as TNF or tumor necrosis factor. So this is an immune system protein that plays a large role in inflammation. The oldest molecule here is etanercept, closely followed by infliximab. The relatively newer kid on the block, which is now more than 15 years old, is adalimumab. Now we have a newer molecule called golimumab. and we have certolizumab, which is not available in India presently. I'll let you know about the nomenclature in my next few slides. Then we have T cell inhibitors. So we know that there are two types of cells of our immune system, the T cell and the B cell, and these are the cells which play a huge part in the immunity. These are the immune cells. So these are cells of our adaptive immune system. The T cell inhibitors block the activity of T cells in the immune system. It is by abatacept. Then the B cells are the cells which produce the antibodies. So we have B cell inhibitors, which would block the activity of B cells in the immune system. And the most common and the one available in our country is rituximab, which is another a very famous B cell blocker. Belimumab is not available in India. Then we have the interleukin inhibitors, and these are the molecules which are specific, which we say they are downstream molecules. Because when I talk of a T cell inhibitor, a T cell comes upstream, then this T cell would come down, would do something, then would do something, and then would a cytokine be produced. This B cell would be activated, it would do something, some antibodies would be formed, and then it would give rise to various immune manifestations. So here, the interleukin inhibitors would block one or more interleukins. The immune system proteins, these are interleukins, they play a role in producing inflammation. The most common of these is tocilizumab, which is IL-6 blocker. Then we have the IL-1 blocker, which is anakinra, which is available in our country via gray market. Then we have canakinumab, which is another IL-1 inhibitor. Then we have secukinumab, which is a IL-17 inhibitor, and ustekinumab, which is still not available freely in our country and is anyways not licensed for pediatrics. Now, you must be wondering what was the nomenclature about. So look at the name very clearly. So this is given by WHO. This is called as a INN classification. When we have a source identification, so in the name, if you look at the last 4 letters, the last 3 letters is a MAB. If it's a MAB, we mean that it's a monoclonal antibody. We have tried to do something to the site, to the cell, and then we have tried to produce a monoclonal antibody, which would go in and which would bind to a particular antibody and then would do further blockade. Now, if you have a UMAB, so UMAB, a MAB prefixed by U, that means it's a human molecule. If you have a OMAB, it's a mouse molecule. If you have a prefix, then you would have a rat molecule. If you have a zoo, so tocilizumab, the zoo would be humanized molecule, means it has got some chimeric protein, but it is largely humanized. And let's not waste time on E and I, and let's look at XI. So rituximab, infliximab, these are mouse chimeric molecules. So when we say rituximab, we mean that here you would have a mouse chimeric molecule. So the chances of reaction are much more. Infliximab, chances of reaction are much more. Tocilizumab, humanized molecule, chances of reaction are still there, but much less. MUMABs, so MUMABs are human molecules. There are practically no chances of reaction, and these can be then given subcutaneously. Even in tocilizumab, now we have the molecule which can be given subcutaneously and IV both. Then, if you will be ending in a sept, so you are a receptor protein. So, etanercept, abatacept, these are the sept, these are the receptor protein. So, this just gives you, it's just nice to know this so that you have a relative idea. It may sound Latin and Greek, but I find it very easy to then decipher this, because now when I tell you I am giving my patient rituximab, then even if you are sitting in a busy pediatric OPD of 100, you can now say, Acha, rituximab, so it's a monoclonal antibody, and eximab means it's a mouse chimeric molecule. So you are confident that at least I know this much. And it's very, very important, because why as a pediatric community, we need to know about this? Because while we are very happy as pediatric rheumatologists to take care of patients with these drugs, when these children get any problems, when these children come to you with any infection, when these children come to you for vaccines, you and I need to be on the same page. You and I need to understand that, oh, this patient has this disease, is getting this drug, is likely to get this side effect. I need to be more careful about screening. I need to be more careful, more proactive in not dissing this patient. Patient calls me up. Patient has just received tocilizumab 2 days back. Patient calls me up sitting in Bihar and tells me that, ma'am, बच्चे को डायरिया हो गया, and I am like, oh my god, diarrhea with tocilizumab is bad news. And I will tell this child to go to the pediatrician, to get admitted, to be there for the next 4 days, to make sure that this child is not running into any trouble, because this tocilizumab can give rise to even a GI perforation. If my child has just received rituximab, then I know that I have blocked the B cells, and I know that the peak effect would come in the next 4 to 6 weeks. And I would tell this patient, if the child has got some problem, to rush to the pediatrician and to be in the follow-up. So the pediatrician and I have to be on the same page. My pediatrician colleagues play a huge role because they are the ones who are going to be managing these children for all their day-to-day routine problems. Now, this is something that I wanted to just say. I did not portray it in the beginning because I thought half of the people would run away. So this is a very busy cartoon, but what it tells you is the interplay, the complex interplay of a T cell, of a B cell, and how they affect a joint. This is from a paper, and this is where the rheumatoid arthritis patients, and they show that how they develop erosions or how they develop a swelling of the synovium. And this is something which is happening in almost all the subtypes of juvenile idiopathic arthritis. So if you look at the T cells which get this is the synovial tissue on the top. So let me use my cursor. Yeah. So this is the synovial tissue, and the synovial tissue has got these endothelial cells, and this is the blood. This has got T cells, the monocytes, and these are the adhesion molecules which you can see. And these T cells have got these receptors, and they come and attach to these molecules. And then we have these antigen presenting cells, and these antigen presenting cells would then something would come from the blood which would irritate these T cells, and they would get activated. And then these antigen presenting cells would present to the T cell, and then this T cell and the B cell get a co-stimulation, and we have some co-stimulation molecules. So abatacept works really upstream, really upstream. And then this is all happening in the synovial tissue, where you have the antigen presenting cell, the T cell comes in, and then it causes a lot of downstreaming occurs. The macrophages are activated. Then we have the IL-17, which is really upstream again. Then we have, then something would help the T cells. And then, without going into much of the immune system, I'll just say that the B cell can be blocked, because this B cell is producing the plasma cell, which is producing the antibodies which are causing the trouble. Then we can block it at the level of the TNF. These are all produced by the activated macrophages. And if we are going to block the macrophages, we are going to land up into much trouble. So we can probably block the downstream molecule of TNF and IL-1. And this TNF and IL-1 they are stimulating the synovial fibroblasts. They are producing a lot of fibrosis, and they are inciting the synovium to proliferate. And then we get a lot of synovitis, and this synovitis gives rise to the effusion which you see in the joints. And over a period of time, if this inflammation persists, they act on the chondrocytes, which are the bone cell, and then they give rise to erosions. So we are blocking the interleukins, the TNF, the IL-1, we are blocking the B cell, we are blocking the T cell by the co-stimulatory blockade. So now I would just tell you about a few of the biologics. So let's talk about the group of TNF inhibitors. So the most common molecule here is etanercept. So elevated levels of TNF, as I showed you, are found in tissues and fluids of patients with RA, psoriatic arthritis, angst, etc. And etanercept binds specifically to the TNF and blocks its interaction with the surface TNF receptors. Etanercept is a fully human soluble TNF receptor. It binds to both TNF alpha and beta, preventing their binding to the receptors on the cell surface, and it is produced in a Chinese hamster ovary mammalian cell expression. The common uses of etanercept are JIA, the various subtypes of JIA, except the systemic JIA, and except in children who have JIA with uveitis, we use etanercept in all the subtypes. Familial Mediterranean fever and TRAPS are the few autoinflammatory diseases where we use etanercept. Behçet's disease, and what I've not mentioned here is the new autoinflammatory disease, the DADA2 or the deficiency of ADA2, where we have to give lifelong etanercept. And as Dr. Anu was mentioning, that these now we don't need to give steroids. Earlier, when we didn't know what to do, we would just give steroids and we would just give methotrexate. Okay, we don't know what the disease is, but you have an autoimmune disease, let's give you steroids. But today, when we have the precise genetic localization, we can identify the disease, we can use precise molecules. The next one in this group is adalimumab, again a fully human monoclonal antibody, again TNF alpha. It binds to the TNF and it blocks its interaction with both P55 and P75 cell surface TNF receptors. And adalimumab, like etanercept, is used subcutaneously. Then we have another one, another TNF inhibitor I've not mentioned here, infliximab. So now our usage is much less with now when we have easier molecules like etanercept and adalimumab, and the chances, because of the iximab, the chimeric molecule, the chances of reaction are much higher, and also the risk of developing tuberculosis is also very high with infliximab. So our usage has much decreased. Infliximab we are using more and more in resistant refractory Kawasaki disease, when the patient has failed 2 doses of IVIG or even 1 dose of IVIG, then we are using infliximab. But because there we are using it as a single dose, so the risk of tuberculosis long term is practically nil. Then the next group is anti-IL-1 agents. So IL-1 beta is a powerful pro-inflammatory cytokine that plays a key role in the innate and adaptive immunity. Dysregulated production of IL-1 plays a critical role in the pathogenesis of systemic JIA. So if we use the IL-1 agents like anakinra, like canakinumab, then we can block this much earlier. Anakinra is also used in many autoinflammatory diseases, especially the ones which are chiropyrin associated. Then it is effective in DIRA, it is effective in LNRP12, FMF, and TRAPS. Now, anakinra right now is not available in our country, but it is also very effective in HLH, especially when it is driven by viruses like dengue, like EBV. So you can use anakinra and you can really save many lives. It is available in the gray market, and currently we are in the process of trying to procure anakinra, but it is not very easy to procure it and it's quite expensive. But some of the children with autoinflammatory disease, their life really depends upon anakinra. And one of it is NOMID, which used to be called as Chinka syndrome, which is neonatal onset multisystem inflammatory disease, where anakinra is life-saving and the only drug that works. Then we have canakinumab, again, another anti-IL-1 monoclonal antibody. Now, the best part about canakinumab is that it is a molecule which can be given once in a month, subcutaneous, versus anakinra, which is given subcutaneous once a day. It's a daily injection. It has got a very short half-life. That is why it is useful in HLH patients, that it's a short half-life. You can just use it and take it away as required. Short half-life of less than 24 hours. Then you have tocilizumab. I'm sure many of you must have heard about it, which is commonly marketed like Actemra. So this is a IL-6 blocker. And we know that in systemic JIA patients, we have high IL-6 levels, and it is a key cytokine in systemic JIA. It is available in India. It is licensed for use in children over 1 year of age of systemic JIA. And it's a recombinant humanized monoclonal antibody. Some patients may get reaction, but overall, it's a very safe drug, and now is available both in IV and subcutaneous forms. So if we look at the safety of these molecules, the TNF inhibitors were the first biologics in PEDIATRIC for the treatment of JIA. The most used TNF in children were etanercept and adalimumab, closely followed by infliximab. They cause a reduced immune response and do create a predisposition to infections. The risk for latent TB reactivation, especially in our country where we have a high TB endemic zone, is much, much higher. Hepatitis B infection also and other infections also increase with the TNFI usage. So what is the general screening used before a biologic is planned? Before any biologic, we need a TB screening, we need a chest X-ray, ultrasound abdomen, and we need both a a MON2 test and a quantiferon gold. And we have studied our own data of more than 500 children with TNF, and we've got many, many children who were negative with MON2 but came positive for quantiferon gold and vice versa. In fact, we have one such child admitted in our hospital recently who was on adalimumab, was exposed to TNF, was exposed to a patient with TB who did not know the diagnosis. And this child is running high-grade fever, has developed a pleural effusion. The MON2 has come positive, and this MON2 was negative prior to adalimumab on screening, and now is quantiferon gold negative, and the child has got MTB in the pleural fluid, which is detected on the gene expert. Also, we do HIV, HBsAg, and hepatitis C antibody, and we do a rescreening for TB every year while a child is on anti-TNF. So, in the next 10 minutes, with the help of a few case scenarios, I'll give you the usage and tell you the scenarios and tell you what is the evidence of using these biologics in various diseases. So this is a scenario where there's a 3-year-old girl who's limping for 2 months, presents with a swollen knee and an ankle. She's ANA positive, RF negative. She does not have any uveitis on screening. She's treated with intra-articular steroid of both the knee and the ankle. So this is a child with an oligoarticular GIA. She's a preschooler. She's ANA positive, so she's predisposed to uveitis. The uveitis risk is there for the next 10 years. Now, after the intra-articular, she remains very well for 6 months, and then now she has got extension of a disease with involvement of a right wrist and other joints. Methotrexate is added. Family is very concerned regarding the side effects. So they switch to alternative therapy. This is a very common scenario. People feel that Ayurvedic drugs and homeopathic drugs do not have any side effects. They don't need any monitoring, and they are very happy to give these drugs. There's a lot of social pressure, and you all know about it. So this child now represents 9 months later with recruitment of one more wrist by now. So by now she's got some 3-4 joints which are involved. Now we have to give this child adalimumab along with methotrexate. And I'll show you the evidence for that shortly. So now what has happened, this child, now this is, wait, right. So when we look at history of 4 or few joints, we would say that you first do intra-articular steroid. Now these are the guidelines. These are the ACR guidelines that had come in 2011 for the treatment of children with JIA. And they clearly tell about if you have a low disease activity, you could do NSAIDs, you could give glucocorticoids, or then if the child is still flaring or has a moderate activity, you give methotrexate. If the disease activity persists, you go on to TNF inhibitor. So this is what was done for this patient. And features of poor prognosis are there. And this is our simplified algorithm, which we use in our clinical practice. I have taken this from the textbook, which is edited by Dr. Sujata Sani and Amit Aggarwal, which is Pediatric Rheumatology, a clinical viewpoint, and where we have, this is for a resource-constrained society. This is for our country where we are very worried about the TB. So this is where we still try to use the same paradigm, but still we do use, we can give one leeway here and there. Now, this child was placed on methotrexate and adalimumab. She responds very well, but we had increased the interval to 6 weeks, and this child had a flare-up of uveitis. Now, what could be the cause? This child responded very well initially. So what happens? All the biological agents are immunogenic because they are non-self. So I want to introduce the term non-self here. Every humanized and even fusion fully human molecule can elicit an immune response, and we get formation of what is called as HACA and HAHA antibodies. These are human anti-chimeric antibodies, and these are human anti-human antibodies. Over a period of time, the T cells and the B cells, they start recognizing, aha, this is not my molecule. This is something foreign. And then they produce these antibodies, which cause a very rapid breakdown of your molecules and very rapid breakdown, and the biologics lose their efficacy. So otherwise, this patient would have been on adalimumab dosing, and I would not waste much time here. And I would just tell you that we need to be aware about the formation of these antibodies. And sometimes the drug levels are available. Sometimes we have to switch a biologic if we have antibody formation for the next one. So after my oligo scenario, I come to another case scenario of a 9-year-old girl who had symmetrical involvement of small and large joints as well as lower limb joints, who's rheumatoid factor positive. And now, what would you prefer? You would prefer a molecule, a rheumatoid factor is an antibody. So you would, it's coming from the B cell. You would prefer something which is blocking your B cell, or you could still go to TNF inhibitor. Again, here the guidelines come to our help. And if we have failed methotrexate, we can go to a TNF inhibitor. If in spite of TNF inhibitor, your disease activity is high, you could go to it, abatacept, or you could go to a B cell blocker called rituximab. So this is your guide for using how long would you use methotrexate, how long would you use a TNF inhibitor, would you switch to another one? Everything is there for you. Features of poor prognosis are involvement of hip and cervical spine, a radiographic evidence or damage, or a joint space narrowing. A positive RF and anti-CCP is a poor prognosis sign and predisposes to erosions. Now, this is our algorithm which we follow here in our center, and this is involvement of more than 4 joints, mild disease. You could wait, you could give methotrexate, bridging steroids, intra-articulars, and you could try a combination DMARDs with methotrexate, hydroxychloroquine, leflunomide. Economics come into play. If there is no problem of funds, then you could go to TNF inhibitor or abatacept. If you have resource constraint, then you could use a combination of DMARDs, as you could see here. So my case 3 is a 5-year-old child who's presenting with fever, high-grade fever. Mother notices a rash. Fever's there for the last 6 weeks. Child has got a involvement of wrists, knees, ankles. The child has got difficulty moving his neck. Acute phase reactants are elevated. So we make a clinical diagnosis of systemic juvenile idiopathic arthritis. And here, this is a very, very complex algorithm, which tells us to use anakinra upfront. This is not available in our country. So we have modified this. And now this is our algorithm, where if you have only articular features without active systemic features, you could go the poly or the oligo articular way. And you could use, but here, instead of anti-TNF, you would use IL-6 as your biologic choice. If you have both active systemic and articular features, you could try with bridging steroids with IV methyl predboluses. But if by 3 months you are resource constrained, you could go to thalidomide or cyclosporin or even JAK inhibitors now. But if you can afford, then you could go to interleukin-6 or interleukin-1 blockers. And as I said, IL-6 is tocilizumab, and IL-1 is anakinra or canakinumab. So these are the EULAR or the PRESS recommendations for the diagnosis and management of Still's disease, and they comprise both systemic GI and adult onset Still's disease. And the recommendations are that there is a high evidence of efficacy of IL-1 and IL-6, and they must be used to avoid prolonged systemic steroid use. So we want 0 disease and 0 steroid, and it's a tall order. It's a very tall order to achieve this. We really have to use a lot of molecules, and we have to do a lot of jugaad. So this is IL-1 or IL-6 inhibitor should be initiated as early as possible. And we should be maintaining a clinically inactive disease for 3 to 6 months without glucocorticoids before initiating the biologic DMARD tapering. This is another case where a 14-year-old presents with left buttock pain, and this patient has got a morning stiffness, also has got some enthesitis. This child is HLA-B27 has a family history of ankylosing spondylitis. This child, again, our paradigm is if you have active sacroiliitis or axial disease, then really, to be honest, nothing works except for NSAIDs and TNF inhibitors. And if you have a hip or tarsal disease, then your NSAIDs, you could combine methotrexate. If there is no improvement, then you could go on to a TNF inhibitor. If you have only peripheral disease, you could still go on to NSAIDs and intra-articulars. If you have a combination, then you could use the biologics. And if you have inflammatory bowel disease, then you would perhaps use sulfasalazine or you would use adalimumab. Principles to use biologics would be: do not start or give a biologic DMARD to a patient who has an active infection. You would wait. Treatment with the biologic DMARDs and also the synthetic DMARDs is associated with an increased risk of infection. Prior to initiation of a biologic DMARDs, a screening must be done for the presence of tuberculosis, infectious hepatitis, and depending upon your local recommendations of fungal diseases like histoplasmosis, coccidioidomycosis, and leishmaniasis should be ruled out. While a child is on biologic DMARD, you should be actively surveying for infections. And while a child is on treatment with a biologic DMARD, vaccination with live or live attenuated vaccines remains totally contraindicated. And all the biologic DMARDs can be combined with synthetic DMARDs, albeit with the risk of higher side effects. But if we add methotrexate to TNF inhibitors, then we reduce the chances of the formation of HACA and HAHA antibodies. So with this, I end my presentation. Thank you so much. And I'm really sorry for the technical glitch in the beginning. Over to you, ma'am.
Good morning, Dr. Baljinder ma'am. Hello.
What a wonderful lecture, Dr. Manjari. What a wonderful lecture. Very enlightening, very knowledgeable. I think everyone must be having questions to ask. You've given a real detailed knowledge upon all the aspects of biologicals in rheumatological diseases. Now, there is there's one question from my side that we have a case, she's a 15 years old girl with JIA. Right now, she's on 0.5 mg per kg steroids and methotrexate. I think 7th dose is there. So in such a case, before starting any biologicals, what are the investigations we should be doing, or when we should be starting with the biologicals in such case, or
Right.
when we should be referring that case to a rheumatologist?
Ma'am, so I would first answer the last question. Ma'am, I think this child should be first referred to the rheumatologist after making a diagnosis so that a management plan can be chalked out. And then the guidelines are pretty clear, ma'am. First, we begin with like how you've done. I don't know what subtype of JIA we are talking about, but whatever subtype of JIA we are talking about over here, are we talking about a subtype with fever?
Yeah, fever, synovitis, inflammation, joint swellings, continuous with steroids and continuous with methotrexate.
So, ma'am, if we are talking about a systemic JIA, sometimes a child with poly JIA also may have some low-grade fever and can have, because of the high inflammatory burden, they can have low-grade fever. So, if we are talking about a poly JIA, then it is okay to give the child a TNF inhibitor. But if we are talking about a child with systemic JIA who's got persistent fever and is requiring a lot of steroids, because 0.5 milligram of steroids, 7 weeks, I think you must be tapering it by now.
Yeah,
so if you are not able to taper, then, and if the child has a systemic JIA, then you could go ahead and give this child a IL-6 blocker, which is tocilizumab. And this you would, of course, now your next question, that what investigations? So apart from your routine investigations of a complete hemogram, a ESR, a CRP, the liver function and the kidney function, apart from that, you need to do a TB screen in this country for any biologic. We have a lot of latent TB. And if the child has got a latent TB, then we first need to treat them for minimum 1 month with the anti-tubercular drugs, and then only can we start the biologic. If a child develops TB during the course of a biologic, then we have to stop the biologic, start the child on the anti-tubercular therapy, and then depending upon how the child is doing, we have to then recommence upon the biologic therapy. So for your patient, I would recommend that you send this patient to a rheumatologist. Even if you don't have a pediatric rheumatologist, you can send the patient to adult rheumatologist, and then they can take over and then chalk out the plan for you, and then you can decide, and then you can give the treatment to this child.
Then there's another question that people continue to give cyclophosphamide, HCQ to children with the SLE for years and years together. So when to shift to?
Right. So because of constraint of time, I had not covered rituximab and lupus. I was kind of hoping that somebody would cover it in the lupus because there's another lecture of CTD coming up in the few weeks. So I had hoped that it would be covered. But to answer your question, you're absolutely right, ma'am, that we should not be continuing to use the steroids and the cyclophosphamide, and we should be using rituximab. And now we have got guidelines. We have the ACR 2024 guidelines, which tell us about triple therapy, and they talk about using rituximab probably upfront. And now we have changed our practice for the last 2 years at our unit. We are trying to use cyclophosphamide only for our very difficult patients, or we are trying to use cyclophosphamide only for our very sick ones, or we are using cyclophosphamide in a protocol, which is a low dose protocol called as a ELNT, or a Euro Lupus Nephritis Trial protocol, which gives a fixed dose of 375 milligram per meter square of cyclophosphamide every 15 days, only for 6 doses. So we really limit the dose, and the maximum dose that can be given in one time is 500 milligram of cyclophosphamide. So that's the max. So even if you have an 80 kg patient, you will use 500 milligram. So it really limits your dose of cyclophosphamide and the side effects also, because cyclophosphamide is associated with high risk of infertility and high risk of infections in later life, and with high risk of malignancy in later life. So we would rather use rituximab upfront in these children to prevent the usage of cyclophosphamide and prevent the overusage of steroids in these children.
So I see a question here that clinical significance of using quantiferin gold test in India.
Yeah, so I was expecting a debate on this. And to be very honest, ma'am, the guidelines are so gray. The guidelines are so gray. If you look at the TB, eradication program, and you look at the guidelines, they don't talk about the quantiferon gold because it is an expensive investigation, and it cannot be the latest technology cannot be replicated at all the centers at large. So we are still using the Montu test. And then there are people who would say that what is the utility of using a Montu investigation in an endemic country? Then how do you really, we miss so many patients by looking at a chest X-ray, because you may not be able to pick up the TB. And latent TB, we really, really need to be very clear about it. So the guidelines for these are Indian guidelines. These are guidelines which are there from the adult rheumatology colleagues, and they talk about doing both. They talk about both doing Montu test as well as a TB gold wherever possible before starting, especially an anti-TNF. If you're starting an IL-6 blocker, or if you're starting a rituximab, which is an anti-CD20 blocker, so there you may not be so het up about TB. But with TNF inhibitors, you cannot be, relaxing, and you cannot be saying that, no, we are not going to be doing TB gold because it is expensive. If your patient can afford a TNF inhibitor, which may be costing not less than 10,000 per month, then your patient can very well afford a quantiferon gold once in a year. So both the tests are needed to detect. If any one test is positive, then we go ahead and do a CECT of the thorax to look at any mediastinal lymph nodes. If there is nothing, then we give the child a treatment for LTBI by using drug ATT. And if the child has got uh, the disease, then we try to get a tissue diagnosis by either a pleural tap or a EBUS or a sputum examination, whatever, or a mesenteric lymph node, wherever the disease may be. So we do try to get a tissue diagnosis and then place the child on a 4-drug ATT. It is mandatory. We just cannot say that no, we cannot do this because of funds. We have to do it. There is no two ways about it.
So, gastric
Ma'am,
lavage
can
for
I
CBR.
interrupt?
Yeah.
Ma'am, this is Dr. Anu. Ma'am, I completely agree with Dr. Manjari as far as TB is concerned. Ma'am, actually, we have also been using biologicals for last 7 years now, and we using the protocol what Dr. Manjari is saying, do a MANTO and an IGRA. Both are mandatory in these children and treating of latent TB. One thing that we do not do is that doing a CT in a child whose X-ray is normal, that is something which is debatable and a lot of centers do not do it. If the X-ray is normal, if the ultrasound is normal, manto igra is negative, or even if one is positive, we treat like latent TB because active TB would be present otherwise also. And igra, ma'am, nowadays it costs around 1,500, 2,000 rupees, and I think most of us are able to do it and we should do it. And not only for TNF inhibitors, I've seen tofacitinib also being started without tuberculosis workup. Manjari, do you agree that we should be starting tofacitinib without latent TB screening?
No, no, no. What I meant to say is that you can still withhold the IGRA if you're giving a IL-6 blockade,
No, no,
but you
not for
cannot.
tofacitinib. Tofacitinib. I'm talking
Oh,
about small
tofacitinib.
molecules.
Sorry. No, no, no.
Yeah,
Small molecules, you cannot. You cannot.
yeah. You have to
You
screen for
have
TB.
to give the do the screening for TB. In fact, we
Yes,
even
yes,
screen our lupus children if we are using tofacitinib.
yes.
We screen them for APLA also.
Absolutely. Because what is happening, Manjari, is that a lot of non-pediatric rheumatology colleagues or orthopedicians or, other PMR specialists also, they're using tofacitinib, but they're not screening for TB, and that's disastrous. I think we should, it's a small molecule, but it's not actually a small molecule.
True,
It is
true, true.
as dangerous as one of the
Yeah, so I have not
biological.
included small molecules here because I
Yeah.
just wanted to stick to my topic. In any case, this was a
Yeah,
huge
yeah. No,
topic.
Manjari, wonderful
So
talk. I just wanted students to
yeah, no,
learn that these drugs
absolutely,
you need to screen for TB. That's
absolutely
absolutely essential. No shortcuts about it.
true.
Then there is somebody's questions. What about vaccination if child is on biologicals?
The ma'am, with the biologics, we have got the guidelines from the European League Against Rheumatism, the EULAR guidelines, and they clearly give us the guidelines that we cannot use any live or live attenuated vaccines while the child is on a biologic, and we can use the inactivated vaccines at any time. There is no restriction for that, and in fact, there are certain vaccines which are promoted, especially the pneumococcal vaccine, which is promoted so for all the children. Then the influenza vaccine yearly is promoted for all the children. And for our lupus children, we do promote the cervical cancer vaccine. So these are some of the vaccines which we promote for these children, and we do not withhold any vaccine. If we have time, if the child has not yet completed the vaccine schedule, if we have time, if the disease activity gives us some time, then we can give the live vaccines and we try to finish the schedule, especially of the chicken pox or the MMR, if that is not done. But sometimes these children don't have that much of time. If the child is sick with systemic JIA, with HLH, then I'm not going to be waiting for chickenpox and MMR. I'm just going to be throwing everything at the child.
Yes,
So sometimes we have
absolutely.
time, sometimes we don't have that much of time, but the guidelines are pretty clear. We cannot use any live or live attenuated vaccine while a child is on these molecules.
Absolutely. Any other question? Dolly, are there any other questions?
I think Dr. Sham is
There
raising
is
his
one
hand.
more. There is one more question, ma'am. Students want to know if the patient gets infection on DMARD, then how do we proceed? Do we stop the DMARD and how can we get back to it?
Of course. So if a patient has got an infection, we need to interrupt the disease modifying agent. Either it's a biologic or a conventional synthetic, whatever it may be. We have to stop. Suppose a patient gets a herpes reactivation, which is pretty common. So you have to interrupt everything. Suppose a patient gets hepatitis A infection, a patient gets a enteric fever, patient gets a UTI, patient gets a URTI, patients get a pneumonia, whatever it may be, we have to interrupt. So it depends upon what infection it is, and the interruption could be as low as, so in a diarrhea illness I may interrupt for only 5 days. In a enteric I may interrupt for 2 weeks. In a herpes infection I may interrupt till all the lesions have scabbed. In a chickenpox I may interrupt for 2 weeks again. So depends upon the infection, depends upon the biologic, and 2 weeks interruption, and then you're back on track. And while on biologics, what I did not mention totally about was the follow-up of these patients, and we have a mandatory requirement of doing a hemogram and a liver function test every 3 months while you are on any disease modifying agent, be it conventional synthetic or a biologic disease modifying agent. So sometimes when we are combining the biologic and the conventional synthetic DMARDs, we may get a lot of transaminitis, and then we have to interrupt the schedule for a bit. Then once the transaminitis resolves, then we can restart, perhaps at a lower dose, but then we can restart.
Ma'am, thank you, ma'am. There is one last question which is not about biological. Someone has asked that they have a patient of 10 years of age with recurrent oral ulcers and culture positive recurrent UTI. There is no uveitis, there is no arthritis, ESR is 20, and the rest of the investigations are normal.
Yeah, so I don't know. This could be just a garden variety aphthy, and why the patient has got a UTI. I think a ped nephro would be much more better to see that why is there a recurrent episode of UTI. And if the high inflammatory markers were there, I would have said with recurrent oral ulcers to evaluate for Behçet's disease, but it doesn't seem like the case.
Thank you so much, ma'am. I think all the questions have
No,
been
no, no. I
answered.
think Dr. Sham has raised his hand. I see his hand raised.
Hello, good morning. Actually, I am as a basically gastroenterologist, and we are the frequently use the biologics. And first of all, I thanks to all rheumatologists because the concept of biologics for the gastroenterologist basically come from the rheumatologist. Regarding the biologics, actually, first of thing, ma'am, you nicely present and taught about the ABC of the biologics, and your algorithm really very informative or resident as well as or leading practitioner or pediatrician. So definitely thanks for the such a wonderful lucid presentation. Regarding the biologics, I request to all resident and pediatrician because one they heard about the biologics, they said कि तुम्हारा बच्चा तो गया है ना. So that is not like things. It just like the sniper gun. Because there's adverse effect is more common with the steroid methotrexate rather than target oriented therapy. But some of the important thing I think you discuss in your presentation, before starting the biologics, you should think that is the right indication. For that, we should use the very well, because now the literature is frequently come with the evidence based. So we should use the standard guideline for the choosing the indication. After finalize that is our indication is right, then we should choose the right biologics. Because in like our gastroenterology, that the Crohn's, ulcerative, that the different biologics work in the different diseases. Similarly, I'm definitely sure in the your rheumatology, the different diseases need the different biologics. So even infliximab is not fitted for the all type of the rheumatic diseases. So before that, we should discuss with our expert. So once you are the planning that child deserve for the biologic, that patient should be shifted to rheumatologist for the benefit of the patient as well as their parents. After that, definitely you rightly said before starting the biologic, we should rightly screen the patient, especially in the low economic countries like the high burden, there the high burden of the latent tubercular infection or some the other. For that, we should the work up properly, honestly. I can't say that every patient should be go through the CT scan, but definitely according to family history, exposure, and other things, you can use the various screening tests to underline the possible infection like the especially TB, viral hepatitis, HIV, etc. After that, I have the slight differ opinion regarding the vaccination because in the our countries that are still we are the giving the immunization only some of the compulsory diseases, but now the times come moving toward the optional vaccination not only for the gardasil because in the biologics as we feel in the gastroenterology very quite common patient after starting the biologic they come with the varicella infection, herpes infection, so we should give the offer to parents to before if we have the time then we should offer to start the some live vaccine especially like the herpes vaccine and other things and try to give the as much as vaccination before starting the biologics especially herpes flu vaccine, hepatitis A vaccines or along with national immunization schedule because vaccination is very important thing because we never know ki how much duration that child required the biologics. So that is vaccination is important things. After that, starting the biologics because that the dose titration is very important. So frequently we use the tough level. Therapeutic drug monitoring concept is very important things to decide the breaking the natural course of the particular diseases. So that's why that is frequently used by the expert, not only by the pediatrician. That's I earlier said that once you planning to start the biologics, it's better to hand out the patient to expert like the rheumatology. That is a good thing. And in our country, because we are the still our income is major important and not like the USA, every child is very well insured. That the cost is very limitations, limiting factor to start the biologic on time. Even in the private setup, you plan ki that child immediately deserve for the biologics even after that proper counseling child parents took the 2 to 4 week at least minimum because cost is very important because it's not like that you start the infliximab one dose then after that they discontinue that is very dangerous rather than it better to not start the biologics. So you should I request to all pediatrician and leading practitioner from the rheumatology we should spare the time properly with the parents for the proper counseling and also involve the other agencies like the in my setup we try to involve the NGOs and we try to find out the other source of the income like the medical social workers they might be give the support of that families but cost is definitely a limiting factor. In the last one we have the meeting with the Ministry of Health regarding this biologics cost in the context of rare diseases. So definitely lot of the government agencies doing the work, wonderful work on minimize the cost of this biologics. But definitely, ma'am, you open in the opening slide, you said the biosimilar because that concept and that research frequently coming from the China side. I thanks to China's people, they are doing the wonderful work on the biosimilars because Baljinder ma'am, biosimilar cost is definitely 80 to 90% reduced. Like the if you are thinking the infliximab cost is 25 to 30,000 injection, and the biosimilar cost is not more than 5,000. So that is a magical cost reduction. But definitely still in the European countries, USA countries, they are not fully agreed about the full support of the biologics because majority of the biologic derived from their countries. So that the revenue loss, but definitely today after listening the today's talk, we got a lot of the information and thanks to ma'am, you did the wonderful job on that. Thanks to all, especially Dr. Ajay, Dr. Anu, Dr. Neha, Dr. Dolly. You did the wonderful job to deliver the such a complicated things to in the very simpler way to our resident as well as our pediatrician. On behalf of IAP, we also recording that session and available on the YouTube because those are the resident they missed the live involvement because of their busy duty schedules. So that the your talk is available on YouTube and there's a lot of the person are regularly watching that recording. So thanks to all team. Thanks to ma'am.
Thank you so much. Thank you.
Thank you, Manjari,
Again,
for the wonderful
wonderful
talk.
talk.
Thanks,
Thank you.
Shyam, for
Thank you,
Over to
ma'am.
you, Dr.
enlightening
Anu.
and reinforcing.
Thank you.
Thank you.
Ma'am, if all questions are done, can we close the session, Dr. Shyam?
Yes, ma'am. Thanks again to
I,
Baljinder madam for accepting
Thank you.
our
Thank you
request
so
as
much.
a chairperson.
Thank you. Thanks.
Thank you. Thank you. Thank you.
Thank you,
thank
ma'am.
you.
Thanks.